the director of the Balkan Center for Children with Glaucoma. I have no conflict of interest in this presentation, in which I'm going to discuss tube shunts and cyclodestruction in kids and how they differ from tube shunts and cyclodestruction in adults. Basically, the indication for tube shunts in children are failed angle surgery, I would say, is the most common, and sometimes those situations where angle surgery doesn't appear to be reasonable. Now, other differences besides the indications with tube shunts in kids is that you have to take into consideration the fact that these eyes are big and thin, and also that they're going to grow. So things change over time. How does that affect what we pick? Well, it does. Even though you think that the eye is in an infant or a small child, really you still need good surface area. So 350 millimeter barbells are often my choice, and I use only valves such as Ahmed in special cases where I'm worried about hypotony. Position is another thing that is of particular importance depending on scarring, and really also the type of conjunctival incision depends on where I'm putting the tube, whether it's superior or inferior, and if this child will need a contact lens. So this is a video, and I'm not going to show the entire video, but I'm going to show part of it to show that I always place a corneal traction suture, which helps with visualization. Use a nice thick suture so that it doesn't cheese wire through. These corneas are not like adults. And then for uh, a limbal incision, I like to keep the uh, uh, the opening about 8 to 10 millimeters posterior to the limbus. The shunt in this particular case is a 350 millimeter, and it's going to go under the muscle. I think one of the most important things about the limbus space is that it allows for such a nice smooth limbus for contact lens, but also for special cases such as aniridia. The remainder of the case looks much like an adult case, and with the exception of the closure, which is double layered with the Tenon's closure separate from the conch closure, mostly because of the risk of rubbing is greater in small children. So there are some special cases where the shunt is done a little bit differently because of the risk of hemorrhage. Sturge-Weber syndrome is one in particular where not only is there bleeding on the surface, but there can be, as you know, serous-choroidal effusion. And the most important thing to consider in this is to avoid any rapid change in pressure. So Helon, no fenestration. This is what I do in order to keep the pressure high, and I just wait for it to come down and use medical management in the interim. Aniridia, once again, I mentioned doing a limbal-based conjunctival incision. I think this is extremely important to not disrupt the limbal stem cells in these compromised eyes. Uveitis, probably one of the only times I use a valved implant is in uveitis. And it is a problem because the surface area is small and ultimately the pressure can become too high and they wind up on medications. If I do a second shunt in uveitis, I will do a 250 barbell inferior nasally. One of the tricks is to really maximize systemic treatment and steroids after surgery. Shunt surgery following congenital cataract surgery, sometimes a first choice for most, but I would say there are some cases where you can try angle surgery first if the angle appears more normal. In these cases, though, it is really important to avoid placing it in such a way that the bevel could be occluded by vitreous. Leave the tube long for direct visualization, and this will help in future management. Complications with shunts in kids are pretty much the same as they are in adults, except remember, the child is going to grow and the tube can move. And in fact, it can appear much closer to the cornea over time than it did when you placed it there. And for that reason, you have to have a nice, easy way to trim these tubes because you put them in long. And this single stab incision with a trimming using a retina forceps is a great little trick, and it requires only one 10-0 nylon and is a nice way to approach this problem. So moving on to cyclodestructive procedures, not often done in children really until their last procedures, unless the eye has poor vision potential, is somewhat unique in the sense that what you're looking for is really just enough to lower the pressure temporarily, I would say. So you have to be very cautious of eyes that can wind up with low pressure prolonged and not do this in uveitis. I think that's an absolute contraindication, or in eyes that have max scleral thinning. I think the biggest thing to know different in children as opposed to adults is that you should transilluminate in order to find the ciliary body. It is not standard as it is on an adult. So you have to transilluminate, find where it is, and aim your treatment. I would say that the powers are also adjusted for children and tend to be lower in the absolute power. And I also, similar to adults, avoid the 3 and 9 o'clock position. Cyclodestruction looks very similar to what it does in adults, except for that you must confirm you know where the ciliary body is before you start this. Endocyclophotocoagulation is nice because you can actually see the ciliary processes, and the treatment feels a lot more precise in these cases. The real trick to this is to have good postoperative steroids and anti-inflammatory treatment, and that will make for a quieter eye, and I feel probably will result in longer pressure lowering than if the steroids are avoided. And if there are any questions regarding tube shunts and or cyclodestructive procedures, the book on pediatric glaucoma surgery certainly reviews this. Thank you.